Coming to you from Portland, Oregon, this is ERCAST, your best source for current issues in emergency medicine, reviews, opinion, and curbside consults. Welcome back to ERCAST. I'm your host, Rob Orman. What would you say is the hardest part of being an emergency physician? There's probably a long list, and I imagine that it's a little bit different for everybody. I often find that the hardest parts are the ones where your level of training does not match the situation. Take cardiac arrest. There's probably no one better trained or more experienced in managing cardiac arrest than an emergency physician. But what do we do at the end of the code when the patient hasn't survived? We tell the family that they died. Maybe the patient was already dead when they came in, or maybe they were telling jokes and talking before they went into arrest right in front of you. But no matter how it happened, you are the one who has to deliver the news. But how much training do we have in this part of the resuscitation? I don't remember it in the last ACLS megacode. In this episode of ERCAST, we're going to talk about how we deliver the news of death. There is some research in this area, but we're not really talking about hard science. This is the art of medicine. As you've probably gathered from previous episodes, we like to look at what actually gets done in the arena, the nuts and bolts of everyday practice. It's one thing to sit in a lecture and hear ideas about it, but it's the real-world experience that makes you better. And what we're going to do is hear the methods and experience of several emergency physicians on how they go through the process of the death tell. We all do it a little bit differently, but as you'll see, there are core elements that most share. It's almost a Jungian collective unconscious. First up is Simon Weaver. Last year, Simon and I were involved in resuscitation of a 2-month-old who came in pulseless and cold. It was probably a SIDS death or a sudden infant death syndrome. We went through all of the resuscitation measures, but it was clear from the beginning that the child was dead. At first, after the child was pronounced dead, there was an eerie quiet. The parents had not yet arrived, and we knew that the hardest part of this whole thing was going to be telling them that their child had died. Let's go to Simon.
Talking about deaths with family members is always a challenge, and it's something that I don't necessarily look forward to. I have a pit in my stomach as I head towards the family room to inform people that a family member has died. But if I enter a room and there's more than 1 or 2 people, I try to figure out who the closest family members are. And I'll try to direct my attention towards those people specifically. It's otherwise easy to get distracted by a dozen family members in a room. I'll try to introduce myself, and then I try to be very direct. I try to use words and language that doesn't leave room for ambiguity. In the scenario of informing family members who aren't aware of the death, it would typically go something like this. I would walk into a room, I would say, "Are you Mr. and Mrs. Johnson?" The parents, for example, and they'd say yes, and I'd say, "I'm Dr. Weaver. I am the physician who's been caring for your child. Your child arrived here 15 minutes ago. When your child arrived in the emergency department, what we found is that his heart was not beating. We then instituted rescue efforts trying to start your son's heart again. Despite our best efforts, we were unable to start the heart again, and your son died 10 minutes ago." And then usually there will be some sort of reaction, and I'll then have an opportunity to do the less formal stuff of offering condolences and my apologies that it didn't work. And then usually after a minute or two, the family will sort of turn their attention to me again, looking for further information. And it's then that I say, "Can I offer you any other information or explanation about what happened?" And they'll usually have some specific questions about what transpired. And then I let them know that I'm available for them as long as they're here in the emergency department to answer questions, and I try to be as open as I can in sharing with them and answering questions with them about what happened. And I guess my primary goal is making sure they understand that a valiant and worthwhile effort was undertaken and that we did our best. My impression is that a lot of family members find consolation in the fact that you tried everything, and when they know that you really gave it their all, it seems to provide them with some solace in the loss of a family member. I think that's one reason why it's helpful having family members in a room, because when they can see the frenetic activity of ACLS measures, I think they understand that, boy, people tried and it just didn't work.
So let's break this down. You enter a room full of people you've never met and deliver the worst possible news. You have no idea of the family dynamics and history or even who you should be addressing. And what people want to hear is, "He's okay," or "He's alive." But this time you can't say it. Even when everything has been done perfectly, there's a sense of failure in the air. And this is part of what makes it so difficult. So if you can, before you even start the process, connect with the social worker or the hospital chaplain. They may have already met the family. They can fill you in on who's there, what they already know, and also how they're coping. I cannot stress the importance of having somebody with you in the room. I have gone in solo, and it does not always work out as well as it does when you have somebody with you, the social worker, the chaplain, and also somebody who may have more expertise in the area than you, and then somebody that you can hand off to at the end. So leave your phone or pager with the secretary and take a minute to collect your thoughts, and also learn the patient's name. Remember that mantra. Sometimes when you enter the quiet room, there's a whole crowd of people, and it's not always clear who you should address. Introduce yourself and figure out who you should be talking to. Within 30 seconds of the time you start talking, and discussing this with experts in the area and the social workers, hospital chaplains, and people who are involved in this much more than we are, that point is brought up over and over again. Don't belabor any kind of explanation. Within 30 seconds of the time you start talking, you need to give the news. He died or she died. That's pretty much what most of us say, that or passed away. You need to be direct and unambiguous. That's the key. Because the majority of what you say, it's not even registering. It's white noise to the people listening. And most of us have learned somewhere along the way not to use cliched terminology like expired or passed on or moved on or no longer with us. There's, somewhere in medical school we've heard the stories of someone delivering the news of death and say, well, they've moved on. And they say, well, where have they moved on to? Can I go visit them? And clearly the patient died, but the family member misunderstood. So there's a few mistakes that you can make after you deliver the news of death. One is over-explaining and delving deep into technical jargon. When you over-explain, it can sound offensive, and too much talking just adds to the confusion and helps nothing. Another is being impatient to leave. You can think of this similar to a procedure where X amount of time needs to be carved out, and you will be unavailable for anything else. Say you were putting in a chest tube. You wouldn't answer a phone call when you're putting in a chest tube, and this is going to have a major impact on these people's lives. So leave the phone, leave the pager, and say, give yourself 5 minutes for the process. And after you deliver the news, give the family a few minutes to absorb the immediate shock. Just be present and be quiet. They will usually break the silence with some questions. Now, here's a question. Should you say, I'm sorry? I've heard several talks where the advice was never use that phrase because it implies that you made a mistake. But you know what? That is BS, because you really are sorry. Yeah, I mean, you feel really sorry for this family. And in most of our job, we're detached. But in this case, it's okay to be authentic with your emotions. Say, I'm sorry for your loss, or I'm sorry it ended this way. And then how do you leave the room? I've always found this an awkward moment. And here's a script that may work. And this gives an example of why it's important to have somebody with you. Say, I'm going to have to excuse myself, and if you have any more questions, I'll be available. And the chaplain or social worker will help you with what comes next. I'm very sorry for your loss. I am the what comes next part being viewing, end-of-life counseling, decisions, etc. Now, before we heard from Dr. Weaver, who's been practicing medicine for about 8 years after residency, and now we're going to hear from Dave Craig, who's been practicing medicine for about 80 years.
Toughest thing we have to do, and something none of us like to do. I think when I approach the family after a bad outcome like this, I think the first thing is to get in the room, touch them so you can get their attention. Obviously, they're usually in one way or another going to be expecting something or be upset or distraught. I think the act of touching is very important. It allows you also to make eye contact, and I think you need to get that eye contact and make sure you have their attention. I prefer not to beat around the bush, ask them too many questions initially. I like to just talk to them for a minute and give them the message as quickly as I can that I've got some horrible news, probably the worst news they'd ever heard. Say, I'm sorry, but your loved one has passed away.
Is that the word you use? You say passed away?
I usually do. I think that's fairly straightforward. I think it gets the message across. Maybe it doesn't sound quite as bad as died, but whatever word you choose to use. I think once that happens, invariably, there's going to be a period of breaking down. I think that's the reason why the touch is nice, to support them at that time, to either stand or sit with them.
So are you holding their hand? Do you have your hand on their shoulder?
Usually it's a hand on an arm or a shoulder. If they're sitting, I may sit down next to them before I give them the message. Hold their hands. Probably in all the best of all worlds, if they're in a quiet room, it's nice to have them sitting because it's such an emotional stress. We've all seen people more or less go out at that point. Give them several minutes, and it frequently takes that for them just to cry and react and without asking any questions. And once that time is over, then they get back and start talking a little bit about what led up to this. They usually do want to tell you at that point, well, this is what happened, and give them a chance to talk a little. At that point, it's extremely important to give them the support and let them know. Sometimes you're stretching the truth a little bit, but they're worried, what should I have done differently? You give them any message other than there really is nothing that would have made a difference. Even if it's stretching the truth, I think to give them that message is quite important.
Do you ever use the phrase, I'm sorry?
Always. And that, you may start off with that when you come in and talk to them. I like to touch them and say, I'm sorry, I have the worst news I could give you, something to that effect.
Here's Ken Bazovi. Ken uses a technique that's pretty common and is exactly what I do. Would call it the recap. And before delivering the news, ask the family what they know. And they'll give a little story, what the events that happened at home. And then after that, you give a little more information on the events from the time where their story stops to the point where the patient was pronounced dead. Keep that very brief. I have found myself kind of going into too much detail about what happened, and that just muddles the picture, and as we were talking about before, can also sound defensive. So let's go to Ken.
One most helpful thing is to just ask them what they know. Not only does that tell you something about the medical history, but it really often tells you how prepared they are to accept the death of a loved one and whether they already have the realization that it's happened. So a lot of times that is really, really helpful. Get a good idea of where the family is starting from. Then when I'm speaking to them, I think the obvious thing is just courtesy and introduce myself and what I have seen here. I always go through some of what I know about what happened. And then at some point, I always try to use the word dead. I think that people are in shock. I think if you use gentler words, they can't penetrate into people's shock, especially if they're totally blindsided by it. Even those people who feel like they're prepared and know that something's going on with their loved one, that they're expecting a terminal event, I think they also are never quite as prepared as they intend to be. I express that to the families who are in that situation where they knew something terminal was going to happen. I think people are always a little bit more upset than they expect to be, and I like to express that that's pretty much normal.
Now let's hear from a few other docs.
When I walk in the room and the family's wondering what's happened to their family member, I introduce myself, I usually shake hands with everybody, then I sit down and the first thing I say is, he died. Because I feel like if you don't say that he died, then you're torturing them by not letting them know what happened. So usually I say, he died. We did everything we could to try to save him. The paramedics did everything they could do. A team of people worked very hard to try to revive him, but we were unable. I think the reason he died was because of a heart attack or whatever it seems like the reason is. And usually I'll talk a little bit about that, and then I'll ask them for their questions. And they usually at the end will say, I'm very sorry.
That the patient has died. Not much after that is going to sink in. And I'll go through some of the details about the resuscitation and what paramedics did, but I want to establish a little rapport before I say that. And I want to make sure that everybody in the room is ready to hear that right then. So I at least spend a minute to introduce myself to everybody in the room, understand what the relationships are, and just try to get a feel from looking at people in a brief interaction to make sure everybody's ready to hear it and hear it right now. Because sometimes there's kids there, sometimes there's a neighbor, sometimes there's somebody that really shouldn't be in the room, or maybe that's not the person I should be looking at. I want to identify who the closest people were, who saw the patient last, get a little sense for if they are expecting to hear that the patient had died, because I feel like the interaction goes a little bit smoother once everybody's on the same page and knows what's going on in the room.
I follow a fairly set script for the first, I would say, 15 to 30 seconds, and then gauge
reactions and my sense of what information people want to have, what's unclear based on their reaction to the warning that their loved one has died. And so basically I'll walk into our family room, introduce myself to the people in the room as the doctor, and tell them that unfortunately so-and-so, their loved one, has just died. Obviously there's usually a reaction at that point, and I will offer some support and consolation, and as it appears that things are perhaps appearing more receptive for more information, I will provide some detail as to what happened with resuscitation, generally try and make an effort to point out things that EMS personnel might have done that were admirable or appropriate, and then perhaps some of the details of our resuscitation, just to sort of give them a sense of the scope of the efforts that were made for their loved one.
Hopefully this gives you an idea of some of the different styles that people use in delivering the news of death. There's really no right way to do it. I think there are some wrong ways or some bad ways to do it, but of all the docs I talked to, everybody was very skilled at this. And speaking of skills, our next guest has some mad skills when it comes to knowing pretty much anything and everything about emergency medicine. Stuart Swadron is an attending at the Keck School of Medicine, University of Southern California, and co-host of EMRAP, Emergency Medicine Reviews and Perspectives. He is one of the preeminent educators in emergency medicine and a Canadian national icon. Let's hear his take on the death tell.
Okay, well, there's those. I think those are all good points, and I agree with them all. And you've probably heard of different systems. There's I don't know any of these things. There's some acronyms. Did I say acronym? I meant to say anagram. I meant to say mnemonic.
Mnemonic. Okay.
There's a few mnemonics on this. Yeah. And they go through things that you should pay attention to, and you should make sure that you're not covered with blood, and make sure you're nice, that you appear professional, usually in a white coat. Some of the things that you had mentioned that you want to do it quickly. I couldn't agree with you more that the more that you talk, the worse it is, because, now I think back on doing this over the years, most of the things that I say are stupid. That's sort of in the best of circumstances. I really think that the less that you say is the better, for exactly the reason you said, which is that you need to communicate clearly and succinctly and quickly after you walk into the room, death. And you have to use those words, okay? And that's in all you see that in all the sources.
Is that what you say? Do you say he died, or do you say passed
absolutely.
away?
Oh, absolutely, absolutely. And I'm not an expert in this, but all the experts will tell you don't use euphemisms and don't beat around the bush. Use the word dead, okay, or died. Don't use all the others. They all say that because there's always a window for misunderstanding if you do otherwise. And once you've mentioned those words, or like you say, if you bring in the Grim Reaper together with you, they already know. That's another way that they can know. They are absolutely not, no data is going in whatsoever, especially silly details, medical terminology, et cetera, et cetera. Silence, I think, is golden. I think very appropriate and time very well spent. Body language, getting yourself down on on the same level, on the same eye level as the patients and their family. Those are all important things. But you didn't call me to ask. I mean, you didn't call me because of that. You called me because you wanted to see if anything might be different in the circumstance of a big urban center like the one I'm at, in the patient population that I'm dealing with. That presumably is what you wanted to get a different perspective at. So
well, that's one, but also just kind of your personal experience.
Well,
what's your method is?
Well, I don't have a method. I barely have a method, when someone is coding in front of me. So I don't have a method for the aftermath. But I think that I incorporate all the things that you just said. I think it gets a lot easier as you get older, and I think the gray hair. I don't know. I think that the people they appreciate that. They appreciate someone who's looks more the part of a doctor, and I think that it naturally is tougher for younger people and for house staff just because of the way that they look like they've been doing it for less time. And I think that that's one of the times where people really like the stereotypical looking doctor. I think that makes it easier for them. It makes more sense for them. It's easier to accept when there's not a bunch of people in their pajamas that look like they're 18 years old or 20 years old. I think that's just makes it naturally harder. So you have to, I think, be better at it. And there's a lot of things like that. There's a lot of things I think that when you're an attending in a teaching program makes it everything easier for you. And I think that we don't sometimes appreciate that. You have to be sometimes much better and do a much more flawless job of things when you're a resident. In terms of your interpersonal skills, they have to be even better than the attendings because things don't come as easier. Things don't come as easy. So anyway, that stuff aside, what's different in the one thing I would add to your to all the voices here is that in the setting of violence involving young people that have died of gunshot wounds and people that have died as a result of a grisly crime, we get a lot of that type of stuff. There's a few additional pointers, and that has to do with security, knowing when to predict, knowing when to expect violence, and knowing how to deal with that. And so we've had times where people have come in as a victim of a shooting, for example, where it's a young man involved. And as the event is unfolding, there are already people sort of anticipation that are coming in while the battle is still ongoing on the street. And so there's a sense of anger related to the uncertainty of what's going on in the hospital, but there's also a sense of anger to the ongoing battle outside and the revenge that's going to be involved. And I've been involved in several situations like that, very sticky. When you start to see people pour in, when you start to see, let's just say, energized family members and friends, and you don't know who's who, you don't know who's running with the person that's involved, you should really start thinking about clearing the hallways, getting security involved. I wouldn't go into the room with a group of people unless you know who those people are. It should be clear that the people that you're death telling to are the family members. You want to have the mom and the dad and the immediate first-degree relatives. You don't want to have a whole cadre of people, of 40 people that you're talking to, some of whom might just be fellow gang members that are going to get enraged. Those things you have to do before you get in the room. And then once you know that you've got the appropriate group in the room that you're going to be talking to, you will need to be prepared for what's going to happen. And I've seen grieving moms attack doctors before. You need to position yourself so that you're close to an exit and so that you do have an out. And you have to have people in uniform sometimes in those situations just visible. You know, you don't want to, the last thing you want to do is intimidate people that are grieving and hearing terrible news with police officers, but by the same token, if a big crowd of people is there and there seems to be, you can feel the tension in the air, it's good to have some uniformed people in view so they know that there's security there and they know that things getting out of hand isn't going to be acceptable. And so that's just things that I've seen that might augment your discussion a little bit.
Now, when I was in residency, and we had a lot of shootings and stabbings, but it's been a while, and we would occasionally do post-mortem procedures. And it was kind of awkward to explain that to the family. We always did, but I never knew quite what to say. I mean, do you and your residents do post-mortem procedures?
No.
Okay.
So there you go. Yeah. No, because and I think probably for the reasons that you just stated, I mean, it's very, very, it's almost no way to broach that topic with the family. There really isn't. And I know when I was an intern, we had, now looking back at it, it's just horrifying to me, but we had a baby, a neonatal death. That kind of thing didn't happen very often, and codes on that age didn't happen that often. And so I remember the whole intern class going down to the morgue to visualize the cords and to intubate the kid, and getting permission from the family. And I can't remember who got permission. I just remember it being a very emotional scene and a very tense scene. I don't know. I'm not passing judgment on it. I just know that it avoids the whole ethical dilemma when you don't do it. And I think that we just get, between what we do in the simulation and now the high fidelity simulation stuff for procedures and just the amount of stuff that comes into our place, we haven't really needed to, do central lines on patients that are after they're pronounced dead, that type of thing that you're talking about. We haven't had to do that.
When you have a young trauma patient who's nearly dead, is it the physicians in your hospital who are bringing up the topic of organ donation?
No, it's not. I think the literature on that is quite clear that this is not something that we should be broaching with the patients. There needs to be a separation between the caregivers and the transplant people.